And we also, thank you, Dr. Nanda. And we also have Dr. Suryani Gunadarma from Bandung. She's an epileptologist and she has involved for wake craniotomy in Bandung. Dr. Suryani, terima kasih.
Hi, good afternoon, Professor. Good afternoon, Selfie. Nice to see you again.
Good evening. Good evening. Hello.
Hi.
And we also already have our wake craniotomy team here, Dr. Viola Maharani, Dr. Diorita, and Dr. Sardiana Salam. Thank you for coming. And we also have Dr. Arwinder Singh from the National Cancer Center Hospital. Hi, Dr. Arwin.
Hello, hello, Professor, and hello, Dr. Selfie. Professor, nice to see you again. I met you last year with Dr. Selfie in Singapore during the low-grade glioma talk.
I remember. Nice to meet again.
Yes, nice seeing you again. Waiting for your talk. Thank you.
Thanks.
And we also already have our other panelist, Dr. Naimi Novitasari from Surabaya. So we are coming from several different cities in Indonesia, Professor.
Good evening, Doctor. I'm Naimi from Surabaya. I'm team of Intraoperative monitoring in Surabaya.
Good evening. Hello.
Halo, Mbak Selfie.
Terima kasih, Mbak. Halo.
Sama-sama.
Mas Boyke belum ada fotonya tapi.
Sebentar, baru online, Mbak.
Siap. Okay. I think we still have another 2 minutes. So I would just like to remind everyone that I think Professor Duffau's presentation would be around 45 minutes. And then we will have discussion for 30 minutes. And of course, I would encourage all the panelists, if have any question, probably at the end of the lecture, then we will open the question for the panelists. I think anyone that would like to ask to say something so that we can just arrange who to talk first. And after a couple of questions, then I'm thinking on moving to the question and answer box. Hopefully we can answer some of them, which I believe we will leave this lecture with more question that's probably doesn't have time to be answered yet, but then maybe we can arrange whether we can send it to your email. And if you have some time, Professor Duffau, and if it's okay with you, then maybe we can just wait for the answer of that question via email, if it's possible.
It would be my pleasure. Yes.
Thank you very much, Professor. That's very kind of you. So I think we already have 200 and no 200 and starting 215 attendees with all the panelists. I'm still waiting for a couple of our team here. Okay, it's already 7 p.m. Is it okay if we start, Professor?
Perfect.
Okay.
I don't know if I can share my screen or if you want to show something before.
I think I would just like to introduce all the panelists to the participant in the very beginning. So, and then I will just introduce you and then we can start, if that's okay. It will just take around 3 to 4 minutes.
Okay.
Thank you, Professor. So welcome to the National Brain Center Neurosurgery Virtual Visiting Professor, the second series. In commemorating World Brain Tumor Day, supporting the fighters, admiring the survivors, honoring the taken, and never ever giving up hope. We are very honored to have Professor Duffau amongst us here to give his lecture about early maximum safe resection in low-grade glioma with a personalized connectome-based approach over 1,000 awake surgeries. Professor Duffau is the professor and chairman of Montpellier University Medical Center, France. He's one of the leaders in glioma surgeries, promoting awake surgeries to get a maximum safe resection in order to have functional neuro-oncology balance for the patient. Firstly, I would like to introduce our panelists for today. Starting from our awake craniotomy team, we have Dr. Sylvia Lumampau, Dr. Made Ayu, and Dr. Asnelia as our neurobehavior team, who will do the intraoperative assessment for the patient. We also have Dr. Sardiana Salam, our neuro-oncologist, and we also have Dr. Diorita and Dr. Viola, our neuro-oncologists, including our intraoperative monitoring team. Next, I would also like to introduce our invited panelists. First one was Dr. Naimi Novitasari from Surabaya, and Dr. Suryani Gunadarma, our epileptologist from Bandung University of Pajajaran, and also our president and secretary for Asian Society for Neuro-Oncology meeting this year, Dr. Rini Andriani and Dr. Tiara Anindita. Dr. Rini Andriani is the neuro-oncologist and National Cancer Center, and Dr. Tiara Anindita is the head of oncologist in our Universitas Indonesia. Professor Duffau was supposed to be one of the invited speakers for the ASNO meeting this year, but unfortunately, due to the pandemic, we have to delay our meeting in Bali to 2022. In the meantime, we are fortunate enough to have his lecture through this webinar. Next, I would like to introduce Dr. I don't think he's here yet, but hopefully he can join us soon. Dr. Joko Widodo, the head of Neuro-Oncology Division from Indonesian Society of Neurological Surgeons, and Dr. Renindra Ananda Aman, the head of Neuro-Oncology Division from Cipto Mangunkusumo Hospital, Universitas Indonesia. And then Dr. Firman Priguna Cahyono, the head of Neuro-Oncology Division from Hasan Sadikin Hospital, Universitas Pajajaran, and also Dr. Ahmad Farid from Hasan Sadikin Hospital, Universitas Pajajaran. We also have Dr. Rahadian Indarto, the Neuro-Oncology Division, Sutomo Hospital, Universitas Airlangga, Surabaya, and also Dr. Irwan Barlian from the Sutomo Hospital, Universitas Airlangga. We have Dr. Julius Julai from the Neuro-Oncology Division, Siloam Hospital, Universitas Pelita Harapan, and also Dr. Arwinder Singh, the head of Neurosurgery Department in Dharma East National Cancer Center. Lastly, I would like to introduce also our neurosurgery team here, Dr. Abra Arham, Dr. Mustaqim Prasetya, Dr. Fadil, Dr. Adi Sulistianto, and Dr. Rian Keswani. Without further ado, we would like to give Professor Duffau time to give his lecture. Please, Professor Duffau, the time is yours. And we share Professor Duffau's screen.
Can you see my slides?
Yes, perfect, Professor.
Thank you very much for your kind invitation. Very happy to be virtually for the first time in Indonesia and to share with you my experience regarding for more than 20 years now, awake surgeries, especially I will speak a little bit more about low-grade gliomas today, about this kind of concept based on the connectomal-based surgical approach could be also applied on high-grade glioma, cavernomas, epilepsy, because it's dedicated to an improvement of the quality of life in addition to the improvement of the overall survival. And now with more than 20 years of follow-up, we reached really this first goal because of course, unfortunately in gliomas patients, we are not still able to cure them. So we have to continue to increase our knowledge. Nonetheless, at least to achieve this first ambitious goal, namely once again to increase the median survival and the quality of life, the secret is, first of all, to do early surgery. And when you meet the first time a patient with a low-grade glioma, the goal is really to abandon the wait-and-see attitude and to propose surgery, including in patients with incidental discovery of this kind of tumor. The second goal is, of course, to extend the resection, and I will develop the concept of supratotal resection according to functional boundaries. Indeed, the third goal is really to do a safe resection, and to do that, the best way is to wake the patient during surgery, to do mapping, but also a cognitive monitoring. Very quickly regarding the natural history of low-grade glioma, because I'm sure that you have exactly the same data. For a long time, it was wrongly said that these tumors were benign and stable. And in fact, you know that these tumors are growing in all cases, will become malignant, will induce neurological deficit, and finally will kill the patient, with a median survival in the classical literature between 6 to 7 years. The second point, classically, we say that these patients are young with a normal life and with a normal assessment. In fact, if you do a very extensive neuropsychological assessment before and after each treatment, because it's not an emergency to do surgery, we have a few weeks in front of us after the diagnosis, and then you will be maybe surprised, but in the vast majority of cases, they are not so well. They have executive functions disorders, emotional disorders, and sometimes problems with social cognition and personality. You can tell me, finally, it's related to the lobar location of the tumor, and this is the reason why we can really understand these kind of deficits at diagnosis. Not at all. It's related to the infiltration of the white matter tract. We demonstrated very clearly that if the tumor is migrating along the white matter tracts at the subcortical connectivity, which is the limitation of neuroplasticity, then the patient will have decline of cognitive function. This is very important to know before surgery, but also during surgery, and before to do adjuvant treatment, especially radiotherapy. When the plasticity potential is limited because the tumor is migrating too much, then the patient will have for the first time seizures. And I have no time to detail this fact today, but we model that when the tumor migrates a little bit too much, especially at the level of the white matter tract, as we said, but also within the cortex, then the patient will have the first clinical symptoms in more than 90% of cases, epilepsy in low-grade glioma. You remember the first series by Mitch Berger 20 years ago, and we reproduced exactly the same results regarding the oncological issues, namely with more than 1,500 low-grade glioma patients, if the volume before any treatment is more important, than the risk to see malignant transformation is higher, and then, of course, the survival is worse. But we introduced the concept of calculation of the growth. It's very easy. You have just to wait for a few weeks before to operate the patient. And in the meantime, of course, you can do a second MRI. And in vast majority of cases, you will see that just in a few weeks, sometimes a few months, then the tumor is growing if you do a volumetric assessment, of course, of the flare imaging. In other words, it's not just a subjective calculation, but a very objective assessment, and it's not very expensive to do that, and I can do that in my consultations with my patient in front of them just in 2 minutes. Why it's important? Because all my patients coming from 5 continents can understand that if a tumor is growing faster, then the prognosis is worse. Unfortunately, this concept, which is just based on common sense, is not accepted by the WHO classification. I don't understand why. Because in the WHO classification today, everything is orientated towards, as you know, molecular biology. But in fact, we demonstrated that the growth rate is not directly related to the molecular pattern of the tumor. For instance, we published this paper in your Oncology demonstrating that you can have a very slow growth, then a very good prognosis in IDH1 wild-type patients. And this is the reason why we reported 2 years ago in Journal Neurosurgery my series of patients operated on for low-grade glioma with IDH wild-type. And you can see that after 7 years, 84% of them were still alive, despite the fact that we did not administrate immediately after surgery, no chemotherapy, no radiotherapy, because the growth rate was slow before surgery. In other words, 95% of patients today in the world will have a STU protocol following surgery for nothing, just based on the molecular biology, which is just a part of the story as we reported in Lancet Oncology with the European Low-Grade Glioma Network approximately 2 years ago. If we do just biopsy, it's not my series because it's a control series based on honesty of people, you know, probably this series in Sweden and in Germany. You can see that median survival, despite chemoradiotherapy following single biopsy, is still around 6 to 7 years. But if you do an objective calculation now of the volume following surgery, which is not done in the vast majority of trials, which is crazy because in fact surgery is the main therapeutic option allowing to change radically the natural history of the disease, then suddenly you can demonstrate that the survival is over 15 years. And this is a prospective series we published already 7 years ago, speaking about the low-grade glioma consortium in France, about more than 1,000 cases. So 6 years versus 15 years. And you will see that we continued to improve the median survival since this publication. The secret is that we have more and more patients alive, enjoying a normal life, and then we can reoperate a second time, a third time. Now I'm preparing a paper about the results after 3 surgeries for a low-grade glioma. Why? Because we avoided to use a post-operative radiotherapy, that plasticity is still efficient, and that patients are enjoying a normal life, including working full-time. So plasticity is induced by the growth of the tumor, and then you can reoperate to decrease the risk of malignant transformation and to increase the median survival. So why to do biopsy in low-grade glioma? There is no reason except in occasional cases with gliomatosis-like. Otherwise, what we have to do is to propose surgery. But of course, to do surgery according to the individual functional anatomy. And then the question is not anymore why to operate low-grade glioma patients, but why not to operate? And the vast majority of cases of neurosurgeons continue to be afraid, especially if you operate earlier and earlier, including in incidental low-grade glioma, as I will do tomorrow morning, for instance, in the left insula with an incidental discovery in asymptomatic patient. Why? Because I will do a mapping during surgery. Because I understood that the vast majority of gliomas are located within so-called eloquent areas according to a localizationist view of brain processing, Broca's area, Wernicke's area, central area, and so on. But I have understood that localizationism does not exist. Fortunately for the patients, fortunately for the surgeon, and fortunately for neuroscientists, because you will see in the end that we published recently a paper in Physiological Reviews, definitely demonstrating that we have to change the paradigms and to forget this classical Broca-Wernicke model. And this is the reason why you will see very extensive resection in my presentations in patients enjoying a perfect normal life. So how to try to better understand the reorganization before any treatment? First of all, to do preoperative functional imaging. But functional imaging is not reliable at the individual level. I can say that because I am PhD in functional neuroimaging. And I can tell you that this functional imaging is not reliable. You can see the sensitivity and the specificity, especially for higher cognitive function like language, executive functions, and so on. So critical if you want for your patient to return to a perfect normal life. We developed the correlation between direct cortical stimulations into the operating theater and the validation of resting state fMRI. And this is a beautiful tool to do research before and after surgery to better understand mechanisms underlying your plasticity. But the reliability at the individual level is only around 85 to 90%, which is beautiful, but I will not take 10 to 50% of risk to induce permanent deficit in my patients, because you will see that I have less than 1% of risk to induce any disabling deficit following surgery. This is true also for DTI. I have the regret to tell you that DTI is not a function, that the reliability is just between 80 to 85%. You cannot select surgery and to do a pre-planning based on this kind of imaging. You can do that if you want, but you are not honest with the patient. And it's not my view. It has been demonstrated recently by the expert in the world. I am not now anymore an expert in engineering and validating DTI, but they did that by themselves 3 years ago and published in Nature Communication that the track programs contain many more invalid than valid bundles. It's not my view. This is the truth today. We have to accept that. So please await the patient. We have the brain of the central nervous system of human beings in front of us. And we can do that every day. It's not expensive. It's very reliable. We can detect the critical hubs, not only at the cortical level, but also at the level of the white matter tract. You remember the limitation of neuroplasticity. It's accurate, it's online, it's safe if you have a good team. And the good team should be based on the cognitive assessment in real time with anatomo-functional correlations performed throughout the resection for 1 to 2 hours approximately. And if you do that, you will have less than 1% of severe permanent deficit. More than 97% of my patients are able to work normally following surgery despite removal of Broca's area or Wernicke's area. But is it enough to avoid language or movement deficit following surgery? Of course not, especially because these patients, remember now, are living more than 15 years. So 2 generations. 1 generation, I'm sorry, 2 decades. So that means that they have to continue to do the same job, the same hobbies, the same leisures, the lifestyle, and we have to adapt the mapping and monitoring into the operating theater according to their definition of the quality of life, and not just to avoid hemiplegia aphasia. I touch wood, but I did not induce any aphasia, hemiplegia for more than 10 years. So this is not really an issue, but this is not enough. We have to increase our knowledge of the brain processing and to take into account the needs of the patient, but also the environment of the patient. We published recently a paper about the fact that if you induce, for instance, hemianopia, to be honest, I don't know in Indonesia, but in Europe, you cannot drive, while in North Africa, you can. Cultural aspect. We have not, in comparison with China or Japan, the same brain processing underlying language, because we have alphabetic language, like in US, while they have an ideographic language. So the neural bases are different. I am not able to offer 99% of reliability when I do surgery in the so-called left dominant hemisphere in the Chinese people. So I would prefer to say, I'm not a good guy. Socioeconomic parameters. I will speak a lot about post-operative cognitive rehabilitation, which is reimbursed in France. This is not the same thing in US, for instance. And then, because the rehabilitation is not perfect, cognitively speaking, in US, it explains why the patient can continue to keep some permanent deficit regarding the higher order cognitive functions. So you see that we have to take into account a full picture and not just the lobar location of the tumor, which means in essence nothing. Because when you will do a resection according to functional boundaries in order to increase the extent of resection, then that means that you have to push this resection until the connectivity. For instance, the yellow fascicles, here, the inferior fronto-occipital fascicle involved in semantic processing. So whatever the location in frontal tumor, for insular tumor, for temporal tumor, as you can see, and for posterior tumor, you should be into the contact of the IFOF in the end of surgery. Otherwise, you left the tumor for nothing. And then that means that your impact of surgery and the natural history of the disease will not be the same. On the other hand, if you cut this pathway, you will induce semantic disorders, even in some patients not aphasic, not hemiplegic. So that means that you have a risk not to be aware about the fact that you induce something which will be wrong for the quality of life of your patients. So to find a good balance between the removal of the most extensive part of the brain invaded by a tumor or chronic disease, I forget the tumor into the operating theater. I will do a lot of investigation before surgery, the volumetric assessment, the calculation of the growth rate, and so on. But during surgery, I see the brain. So I can do that with no technology at all. No image-guided resection. Imaging is not the tumor. Imaging is not function. Everyone knows that. So no DTI, no fMRI, not before and after to better understand mechanisms, but no functional imaging during surgery. No navigation, no intraoperative MRI, no microscope, no electrocorticography. You can do that with a fork and a knife. So everyone in the world. And at noon, every day, it's finished, despite a very extensive resection of the left insula, for instance. Neurosurgeons are telling more and more, we have understood. We are doing more and more awake surgery in the left dominant hemisphere. What means left dominant hemisphere? To do surgery within the left hemisphere tomorrow, I need my both hemispheres. Otherwise, I will not be able to adapt my strategy online according to the feedback provided by the patient. In other words, I need my brain. If it's true for me, it's true for my patients. So it's not possible to say, oh, the right hemisphere is non-dominant. Non-dominant. For movement, if you want to be a surgeon, you need bilateral, very accurate manual, skill. And you need to have very accurate movement, and just to avoid to be hemiplegic is not enough to play piano or to do surgery. Spatial cognition, if you have hemianopia, but if you have also hemi-neglect, you cannot drive. Social cognition, You cannot have normal affect and normal insertion in the society if you have some mentalizing deficit. Non-verbal semantics. In the vast majority of cases, you can adapt to the environment while no one is speaking. So that means that we can understand what happens without language. Executive working memory function, to be able to do many things simultaneously. Personality, emotion, we are human beings. So how is it possible to say that all these functions are not critical? Of course they are. So you will tell me that it's not possible to map, to monitor these functions into the OR. Of course it is. It's exactly what we are doing for more than 10 to 15 years. Initially, I did only movement and language, and I was wrong. But now I have better understood brain processing and the interactions between different networks. So this is the reason why I will do awake surgery regardless the location of the tumor. If the patient is telling me, of course, I want to continue to enjoy normal life. And now everything is possible because we have understood that Broca's area does not exist. I simulated past week Broca's area not invaded by a brain tumor. And what happens? Nothing. And what I did is to go through Broca's area in order to reach the insula in the depth, and the patient is well. Of course, we have to add other further tasks according to the needs of the patients, as I said, but now very practically, if you are a mathematician, you can include calculation. If you are a dancer, you can include a line bisection task in order to avoid any neglect in the so-called right non-dominant hemisphere. If you are a writer, you need more syntactical processing monitoring. But once again, in all cases, we need to monitor mentalizing, empathy, emotion, theory of mind. We are human beings. So independently of the location of the tumor, except if you do not offer this choice to your patients. So that means that we are not in agreement with Hippocrates to give all information, and finally, the patient will decide. The most important now is to understand that if you cut the connectivity in the depth, then the patient will never completely recover. Everyone can understand, speaking about the posterior limb of the internal capsule, if you cut the pyramidal pathway, of course, the patient will be hemiplegic. But is it enough? Now, speaking about bimanual coordination, if you are, for instance, a cellist, you like to play music. We published in Brain past year the cortical map of the areas involved in the control of movement, not the execution, but the control. And of course, the cortex is not enough. So we identify the pathways involved in this complex bimanual coordination, namely the frontostriatal tract. So if you stimulate it while the patient is doing movement, it will stop movement. This is very important to know because we have the same problem. When you operate within the parietal lobe and not just the somatosensory tingling induced by the stimulation. The feedback is critical, but it's not enough. And I know that when I was younger, I used some modification regarding the awareness of body schema in some of my patients. And finally, we published that in Brain 2 years ago. So that means that I needed many years in order to understand that we need this frontoparietal loop in order to have a beautiful movement and not just to monitor it using MEPs into the operating theater. This is not enough. The vision, once again, if you cut the optic tract, you will induce hemianopia. We have to ask to the patient before surgery, is it acceptable or not for you? And to wake the patient in order to avoid it. If the patient told you, I don't want hemianopia because I need to continue to drive. This is true at the level of the connectivity in the so-called right non-dominant hemisphere to avoid any spatial awareness deficit. You have to know that the part 2 of the superior longitudinal fascicle is absolutely critical. If you cut it, you will induce permanent hemi-neglect, and then the patient will not be able to drive. You will say, my patient is well. No, if the patient cannot drive, he cannot enjoy a perfect normal life. So we lie. Regarding language, stop to say that Broca's area is connected directly to Wernicke's area. This is totally wrong. Never it has been demonstrated. It was just imagination of neurologists. It has been demonstrated that the ventral premotor cortex behind the so-called Broca's area is connected to the Wernicke's area, and it is involved in the articulatory processing. The SLF3, the lateral part of the superior longitudinal fascicle in blue here, but to the arcuate fascicle connecting the pars opercularis and triangularis to not the posterior part of T1, but posterior part of T2 and T3, in agreement with the model well known now in cognitive neuroscience, but not accepted in neurosurgery. That's crazy. We have to accept also that the ventral semantic pathway is absolutely critical and not just the dorsal phonological pathway. So if you stimulate the IFOF, we spoke about it a few slides before, then you will induce semantic paraphasia in the so-called left dominant hemisphere. But you will see that in the right, this IFOF is also very important for non-verbal processing. If you cut the inferior longitudinal fascicle, then you will induce an increase of reaction time regarding lexical access. You have not to decide if it's critical for you or not. You have to ask the patient, can you tolerate that? It will depend on his or her definition of quality of life. Or if you cut the posterior part of the ILF, you will induce modification in the reading. You have not to decide by yourself if the patient can tolerate alexia or not. You have to ask. But what is absolutely amazing is that the brain can compensate or mistake. And if you cut the ILF and the incinate fascicle, then it could be compensated by the IFOF. In other words, it's not a compensation one area by another one, but a subnetwork by another one. And you will see finally that now we have to see the relationships between networks, and then it will create behavior. Speaking once again about the IFOF, when you stimulate, you will induce semantic paraphasia, but in the right non-dominant hemisphere, you will induce modification in the understanding. And the risk is for the patient to give you the good name while he understood nothing. For instance, if you have to associate gloves with hands or feet, and the risk is for the patient to tell you feet. So that means that he can speak, he can name, but he cannot understand anymore. And for you following surgery, you will say, patient is able to speak, so you see, is well. Not at all. He will never return to a normal life. And I have the regret to tell you that the right IFOF in the so-called non-dominant hemisphere is critical for non-verbal semantic processing. So for the understanding of the word, because we need language and non-language. And it's true also for the mentalizing, namely the empathy, the theory of mind, the social connectivity. We able for many years to ask patients to recognize or not the emotion expressed by faces and especially eyes in front of them. When you stimulate, they can say, oh, I cannot recognize anymore sadness, for instance. That's true cortically, but that's true also at the level of the IFOF, including in the right non-dominant hemisphere. I have changed the personality of my patients when I was younger and when I did this kind of surgery in the right so-called non-dominant hemisphere under general anesthesia 20 years ago. And my patients were depressed. And my colleagues told me it's normal. He has a brain tumor, so he's depressed. Not at all. It's because I had the IFOF. And I was not aware about that at the time. Now I know. And now I can avoid that. So if I can avoid, you can avoid. The question is, are you ready to talk about that with your patient before to go to the operating theater? This is a model we did recently of the so-called non-dominant hemisphere. You can imagine the number of networks involved in semantics, including language sometimes, mentalizing. Okay, I will not detail again. You have understood. How is it possible, to your opinion, to operate under general anesthesia by telling to the patient, don't worry, you will recover? We lie to the patient when we say that. So, because I cannot lie, because 90% of my patients are coming from abroad, because I have the habit to ask to my colleagues to do systematic linear psychological assessment before, but also after surgery, I will give you my results. About more than 800 diffuse low-grade glioma patients, so more than 1,000 awake surgeries, because as I told you, initially, more and more I have the habit to reoperate my patients still alive. So approximately, I reoperated on 1/3 of my patients today, but I will continue, of course, this prospective collection of data. So despite the location in so-called eloquent areas, but you have understood in the localizationist account of brain processing, which is totally wrong, fortunately, the mortality is 0, and I have less than 0.5% of severe permanent deficit related to 2 deep strokes I had when I was younger at the level of the anterior perforating substance. Now I understood that the right eye fourth is protecting me because it's lateral at the level of the temporal stem, so you are protected from the lenticular striate arteries. So the past 10 years, rate of severe permanent deficit is 0. But what is really extraordinary, despite this very extensive resection, you have 30% of improvement demonstrated objectively in post-operative cognitive assessment related to the post-operative rehabilitation, and because we preserve the connectivity. So we did surgeries according to functional boundaries. Plus, we improved 80% of our patients who had epilepsy before surgery, because we demonstrated that epilepsy in low-grade glioma is not related to the core of the tumor, but the periphery, the invasion of the cortex around the tumor. So more you will remove, more you will increase the extent of resection and decrease the risk of malignant transformation and increase the overall survival, but more you will improve the quality of life of patients. Of course, if you preserve the critical networks. If we can do that in Montpellier or in San Francisco, you can do that everywhere in the world. It was the message of the meta-analysis we published with Mitchberger 8 years ago in JCO. But now what is very exciting is to better understand what we did by performing this kind of extensive resection, speaking about brain reorganization in order to anticipate a second or even a third surgery by dealing with brain plasticity. And functional imaging, because non-invasive is absolutely beautiful to do pre and post-operative explanation of this reshaping. For instance, here you can see patients who recovered following a transitory supplementary motor area syndrome, and you can see the activation, the recruitment of the contralateral SMA, contralateral premotor cortex, plus, of course, the central area with the precentral, retrocentral, parietal lobule, and so on. So a bilateral network compensating this very extensive resection. Why it's so exciting is because you can come back a few years later without inducing any limitation of neuroplasticity if you avoid radiotherapy. We will speak about that very quickly in the end. Here, for instance, I removed the club of the hand 5 years later because remapping occurred in the meantime. Of course, the patient continued to enjoy normal life. Recently, because it's very recent, in fact, we published a paper with fMRI before and after surgery regarding language and not just movement. And then you can see that we started just to show modification in the balance between hemispheres, interhemispheric connectivity. What means non-dominant hemisphere? It's a brain. And now you will tell me, we don't care just neuroscience. Not at all, because when you cannot remove completely the left temporal lobe during the first surgery, and because I hate to lose, I came back 10 years later and I removed the so-called Wernicke's area, without any problems, because plasticity occurred in the meantime, helped by the post-operative cognitive rehabilitation, but also because I preserved the connectivity 50 and 46 in the depth, namely the arcuate fascicle and the inferior fronto-occipital fascicle. So the dorsal phonological pathway, ventral semantic pathway. This is exactly the same thing at the level of Broca's area. I was not able to remove the pars opercularis during the first surgery because still eloquent in this patient at the time, we have not the same brain. Okay, I accepted because I did not want to induce any permanent deficit. Patient enjoyed my life, no chemotherapy, no radiotherapy. And 10 years later, I came back in order to remove the Broca's area without any problem. So you can see that sometimes we can really be very provocative by removing 10 years later, second, the contralateral frontal lobe. You can believe me or not, but this case report was published in Brain and Cognition with 4 hours of cognitive assessment and behavioral assessment. This patient is normal, enjoying normal life, taking care of his family, driving, working full time, and so on. And once again, it's not because you will incorporate more tasks during surgery that you will have less externalization. This is the reverse, because now I have more than 16 years of survival in my experience, with 25% of my patients still alive with more than 20 years of life. So we changed radically the history of the disease, especially when it was possible to do a supratotalization, namely to take the margin beyond what we can see on the preoperative MRI, because the flare is not the disease. This is the reason why it's dangerous to use intraoperative imaging, because the functional imaging is not a function, as I told you, but the flare is not the disease. If you can remove more, what happened? No malignant translation, no death with more than 10 to 15 years of follow-up. Maybe some patients are cured. So you will tell me it's very difficult also to do systematically a supratotalization to take a margin for functional issues. This is the reason why we have to arrive earlier and earlier. And why not in incidental discovery low-grade glioma? Why? Because if you do a cognitive assessment objectively in patients with incidental discovery for migraine, for instance, in 60% of cases, 60, you will identify cognitive disorders. They have a brain tumor. Because you have a risk to see a sudden explosion, acute malignization, transformation, while the patient is still asymptomatic. For instance, in this case, the patient was referred to me 4 years later, while he was followed in another institution. And unfortunately, it was now a glioblastoma. And I did, of course, the job by removing the tumor, but the patient died 3 years later because it was a secondary glioblastoma. Now, imagine that I was able to do a supratotalization when the tumor was discovered. And remember, with more than 10 to 15 years of follow-up, the rate of death after supratotalization, in my experience, is 0. So in other words, by doing wait and see attitude, we killed the patient. So what happened when we did early preventive surgery in patients with incidental discovery? I did more than 100 patients. And of course, because the tumor in essence are smaller, I did 30% of supratotal resection, plus 30% of complete resection. So 60%, no partial resection. Already, malignant foci were identified in 30% cases. So we changed radically natural history of the disease. No epilepsy, no deficit, of course, because we arrived before then the brain reached its limitation regarding plasticity. You can tell me, yes, of course, they have beautiful scores, but what about their real quality of life? We published this paper this year in Neurosurgery by telling that more than 95% of patients resumed also their employment with, you can see, so a very good externalization. So we propose now in front of the National Academy of Medicine in France 2 years ago, and it has been accepted to do a screening in the general population, at least in younger people between 20 to 40 to start. And of course, more we will identify smaller tumor, more we will do supratutorization with a perfect preservation of the quality of life, because we know the limitation of neuroplasticity. We published an atlas in brain in the MNI template 4 years ago in order to say to neurosurgeons, you know, before surgery, the externalization related to the probabilistic map to recover or not. Of course, it could be beyond neurosurgery and recovery following stroke, for instance. So why it's important? Because you can say sometimes, no, I'm not able to remove completely the tumor, like in this case, because there is an invasion of the contralateral hemisphere, and I know that we need to preserve the connectivity at the level of at least one hemisphere in order to compensate. So in this case, what we did, just partial resection, temozolomide, shrinkage, second surgery, and you can see that at that time we achieved a complete resection, even including the corpus callosum. Another example, first surgery, temozolomide, shrinkage, second surgery. The patient had 10 seizures a day before surgery, not able to drive, not able to work. Now, no seizures anymore for many years, able to drive and to work. So improved the quality of life by doing that. And you know what? This tumor was not 1p92 co-deleted. In more than 50% cases, you will induce a shrinkage using temozolomide, so preserving the quality of life, while the molecular profile is not in agreement with the recommendation by the EANO. We don't care. We have to individualize the management and not to apply just a protocol. Because if we love evidence-based medicine, remember that it has been demonstrated using a prospective randomized trial that if you do early radiotherapy, you do not change the median survival in comparison with no early radiotherapy, but you will induce a decline of cognitive function. And you know why? Because you will irradiate the minimal common brain, the limitation of neuroplasticity, in other words, the connectivity. And now, finally, after 20 years, some honest radiotherapists start to do pre and post-operative pre and post irradiation, cognitive assessment with pre and post DTI. And as you can see by yourself, they say that just after 1 year, it was a decline of the cognitive function related to problems at the level of the white matter structures induced by radiotherapy. And this is the reason why even the ENO, Monica Egi by herself, proposed recently to defer radiotherapy for a better preservation of cognitive function and quality of life, regardless of the 1p92 status. So molecular biology is dangerous at the individual level, dangerous. So we proposed to adapt the strategy by doing, first of all, an extensive resection according to functional boundaries, this patient at that time, then to induce plasticity by doing post-operative cognitive rehabilitation, and then to return to a normal life, which is the goal finally for patients to enjoy a normal life as human beings, to reoperate a second or if possible a third time, if it's not possible because the invasion of the connectivity, to do chemotherapy regardless of the molecular pattern, and finally to postpone radiotherapy. And now I start really to irradiate my patients after 10 to 15 years, before, of course, malignant transformation, but no early radiotherapy. And what happened once again, more than 16 years of median survival. It's not my imagination. We proposed recently in neurology to avoid to give adjuvant treatment after extensive resection of a so-called low-grade glioma with foci of malignization in the middle. I mean malignization grade 3, or even with some foci of glioblastoma. You can see 5-year survival rate more than 95%. without any stop following this kind of treatment in this kind of tumors. Example, you see that you have really announcement that it was really a high-grade glioma. But I did a supratotal resection. It was 70 years ago. What happened? I did no chemotherapy, no radiotherapy, and the tumor, of course, recurred because I cannot cure patients with diffuse glioma. So I did a second surgery 3 years ago. And at that time, the neuropathology told me it's a low-grade glioma according to the new classification. No chemo, no radiotherapy. So in the vast majority of cases, patients are over-treated for nothing. To conclude, it's very important to understand the connectivity of the brain, because we have not the same brain, and the brain is not the same over years in the same patients. So we have, first of all, to be neuroscientists and to be able to publish also in Science or Nature or physiological reviews as neurosurgeon doing the job every day into the head and the brain of the patients. It's not antagonist, it's a potentiation. So in order to help neurosurgeons, and especially younger neurosurgeons, to build in their mental imagery this kind of knowledge of the connectivity, which is of course endless, we published recently the third atlas in the world literature showing both the cortical and the subcortical white matter tract critical for brain functions, speaking about 16 functional domains: movement, control of movement, language, semantics, mentalizing, you have understood. But what we said now is to model not only the left and the right hemisphere, but their interactions in order to propose the concept of a meta-networking brain, namely that we have to see now the interactions between not only different subnetworks, as we have detailed, but between networks constituted by themselves of subnetworks. And then we can start to understand the principle of adaptation, of adapted behavior according to the environment, the real neuroplasticity. And this is very important when you do a stimulation, because I went to so many countries in my life, more than 50, 60. I have seen so many colleagues using stimulation into the operating theater and finally putting the probe at the level of the cortex, inducing a transitory deficit, and to say, this is the area corresponding to the function. No, this is just an entry door because we induce disturbances within the whole network. But sometimes disturbances also between networks. And this is the reason why we ask systematically to patients into the operating theater to do at least 2 things simultaneously, just like naming a movement, for instance, because it's not 1 + 1. Because sometimes if you disrupt the meta network, the patient is still able to move, is still able to speak and to name, but is not able to do 2 things simultaneously. So that means that for you, it will not be hemiplegic, it will not be aphasic, but for him, her, it will not be able to return to a normal life, including to work. So the take-home message is that when we are into the brain of human beings, we have not to see the glioma because it does not exist, because the glioma is diffuse. We have to talk directly to the brain of this patient at that time. And never fMRI, DTI, technology, what you want, robot, will give you this kind of so subtle information. You have to weigh the patient, you have to benefit from strong interactions between different members of your team, your psychologist, neurologist, speech therapist, and all of us, we are PhD in cognitive neuroscience. So we can speak about just clinical considerations, but also scientific considerations and everything simultaneously around the patient online. And if you need too much technology, especially for younger people, you will become addicted. And finally, never you will be a real brain surgeon. So now you have the choice, or just to remove a tumor according to the pre-planning made by the artificial intelligence and guided by a robot. So that means that more or less you are nothing anymore, or to treat a human being from the beginning to the end, namely to better understand his needs, to better understand his quality of life before to go to the OR, to adapt the strategy into the OR, not just according to your knowledge of the anatomy, but according to the wishes of the patient and your knowledge of the connectome, and to guide the patient for the adjuvant treatment, including radiotherapy, until the end. And the end, I don't know, because I have only 24 years of follow-up, and I hope that if I have the opportunity in a few years finally to come to your beautiful countries, I will add new ideas, new concepts, new results, and a longer follow-up. If I can do that, you can do that, so good luck.
Thank you very much. Thank you very much, Professor, for the eye-opening lecture. It's amazing how now you have the MRI screening for the glioma in young patient. I think it's amazing how you lean towards a preventive and individualize the functional neuro-oncology to treat the patient. And I understand that there must be plenty of questions coming from the participant and also the panelists. So I would like to start maybe from the panelists. If anyone have questioned, I think we have 30 minutes, right, Professor?
It's perfect for me.
Thank you very much, Professor. So from the panelists, if there's any question, would you mind raising your hand? I think Dr. Firman Priguna has some question. Please, Dr. Firman.
Yeah. Thank you, Dr. Selfie. Thank you for inviting me as a panelist here. You have performed a wonderful webinar here. Great participation, 400 more. Congratulations, Dr. Selfie. And Professor Duffau, good evening. I'm a big fan of yours. I follow your presentation all around the world. And last, I met you at Singapore. Maybe you don't know me, but I see your presentation is very great. Sometimes I'm afraid of operating this such of kind of case, low-grade glioma, because I'm afraid I'm making worsening of the patient. So your way is kind of wake me up. I think we can do that. As you know, we don't have a expensive equipment such as neural navigation or something, but you said you don't need that. You don't need neural navigation and you don't need microscope, and that's amazing. So before your presentation, you said that you have some kind of tools, some kind of equipment, that it was a cheap one or maybe a simple one. Dr. Selfie said it, but can be monitored, the functional monitoring. Can you explain it further about your equipment that you use to perform surgery, Professor? Thanks.
First of all, speaking about the microscope, I will tell you something maybe a little bit provocative, but microscope in this kind of tumor is dangerous. Why? Because I have seen very good surgeons, including when I was younger and they were better skilled and with greater experience than me. But under microscope, they would like to try to fill the tumor and to avoid any bleeding. And finally, they coagulated the white matter tract in the end. And finally, it was the limitation of neuroplasticity with a sudden drop, explaining why their patient did not perfectly recover, because they would like to have a beautiful operating field, but they had no holistic view of the functional anatomy of the connectome of this patient at that time. While if you remove the microscope, suddenly you can see the cortex, the critical areas, but you can see also the pathway in your mental imagery. And if you want to add your navigation initially to check, you can do what you want in addition to, but in fine, the validation will be given by putting a bipolar probe at the level of the white matter tract, and by thinking I am into the contact of the I4 because this is under the circular sulcus of the insula, for instance. I try to see the surgery I will do tomorrow. And at that time, and when you use semantic disorders, you say nothing, of course, and the speech therapist or the neuropsychologist will tell you when you will stimulate at that time semantic disorders. So you say, okay, I know exactly where I am. I cannot push the resection even if there is a residue. I can, but the patient will have problems. So I will use to do that bipolar with biphasic current, monopolar, bipolar, you know, finally we didn't care because it's just a validation. So I have no seizures in my operating theater. Why? Because I will use a very, very low intensity between 2 to 2.5, not 10 milliamps like in the literature. I don't want to induce after discharge. It's not to identify the epilepsy focus. I'm not an epilepsy surgeon. So it's totally different. So you have to remove the ECOG. And the most important is, of course, the feedback provided by the patient, but also by your team. And I can tell you that I cannot do this kind of surgery with a high level of reliability without the beautiful tool, if I can say, my neuropsychologist. Because, yes, this is the secret. He will tell you, it was a semantic problem, but not directly related to language, but probably related to the non-verbal semantic processing. Are you into the contact of the right IFOF? Yes, I am. Thank you so much. So you see, you can see this kind of meta-network disruption you have seen in the end, and you can have the feeling by looking at my presentation that it's just esoteric concept in order to write beautiful papers in high journals, but not at all. It's exactly what we have in your mental imagery between the neuropsychologist and myself. And when we do stimulation, of course, double blind, I will never say I will stimulate. There is no noise. There is no transparent field. It should be double blind. If I have this kind of answer, it's strange. We have a low-level mentalizing problem. Maybe you are into the contact of the cingulate. Is it right? Yes. Thank you so much for the confirmation. So you have to stop. And never the microscope, even with the robot, even with the intraoperative MRI, will give you this kind of so accurate information, because we have to learn to speak the same language. So we have, first of all, to be neuroscientists, and then finally operated on the brain with just the subpial dissection technique. So I do not coagulate within the brain, so I have no stroke, and without microscope, because I have a full picture of the connectivity according to our last papers, for instance.
Well, thank you, Professor. Very inspiring. I'm going to try to follow you. and thank you for your explanation. And the last, I bought your book, Mr. Duffau, to teach our resident. Thank you for your time.
Thank you so much.
Thank you for your time.
I think now I have to write a third edition, because I learned so many things just in the 3 years. It's endless, and there is an acceleration of what we can learn thanks to also an increase of the technology, but outside the operating theater. Yes. You have seen, for instance, the paper we published recently with pre and post-operative fMRI language. It has been impossible a few years ago, and now, thanks to the better understanding of the connectome, thanks to the theory of graph and so on, and the increase of the reliability, speaking about the biostatistical model, then suddenly I can finally start to understand posteriori what I did. So the goal now is to try to predict a priori before to redo surgery in the same patient 5 years or 10 years later.
Very inspiring, Professor. Thank you for your time. I really appreciate it. Back to Dr. Selfie.
Thank you very much, Professor Duffau. This is why I think it's very inspiring how you always try to push the boundaries. When you have the limit, then you push where you can do more and more. is so inspiring for us, especially for the young neurosurgeon like me. I saw that there's a question from Dr. Renindra.
Yes, thank you, Dr. Selfie. Excellent presentation, Professor Duffau. Thank you very much. And in 2014, during the European Congress in Prague, if I'm not mistaken, you gave a talk also about the management of low-grade gliomas with Mitch Berger, right? So during 6 years, is there any significant change between your talk 6 years ago and right now? That's my first question. And the second question is, in your book, you mentioned about the cerebral processing are underlaid by parallel distributed and interactive networks called hodotopy. Can you explain to us neurosurgeons the importance? Because during low-grade glioma surgery and awake surgery, sometimes our team cannot identify the Broca area, even after multiple just cannot find. You said Broca is not really the speech center. And what does that correlate with the hodotopy or the rodal pathway of this network? And the third, that you mentioned you didn't use or you don't want to use microscope. So that means you need the feeling, right? The feeling that when you touch the tumor or you touch near the eloquent area that doesn't have a cell tumor, that means you have to learn that feeling. Is that right? Thank you.
Regarding the third question, no, that's not right. I have no feeling. Once again, into the OR, I forget the tumor. I don't want to remove a brain which is a little bit different regarding the texture. I am not a surgeon. I am a scientist. So I will stop according to the connectivity. So that means that this is the answer to the second question. What we have learned these past 6 years regarding the hodotopy and finally the meta-networking theory means that in this example, which is very provocative, as I said, if the patient is normal, really, regarding the cognition, the emotion, the personality, and so on, is because we have preserved the networks and the interactions between the networks at the level in the essence of the brain, which is still in place. And we were able to do a very extensive bilateral frontal lobectomy because there are some mechanisms of modification of the weight between different nodes in these complex networks. And this is the reason why, even if sometimes you can stimulate the pars opercularis of the left inferior frontal gyrus and to have some modification of language, and you can say, ah, you see, Broca's area finally exists. Yes, in this patient at that time. But please come back a few years later, and you will see that thanks to this complex and dynamic organization using both hemispheres, then finally you will remove this area, so more tumor, and you will increase the median survival, which is the answer to your first question. In comparison with 2014, I have added plus 6 years, and now my median survival is not 10 years, but 16 years median survival in comparison with 6 years according to a single biopsy or the seminal paper by Martin van den Bent in Lancet. So we added 10 years, not against the quality of life, because in the meantime, I have learned that in the right hemisphere, they were so complex networks that we have now to preserve, speaking about beyond language and movement, cognition, emotion. So I don't know what we will add within the next years, but I think that it will really deepen now on the better understanding and acceptance of this complex brain processing, not only by neurosurgeons, but also by medical oncologists and especially radiotherapists. In other words, I cannot tolerate that we as neurosurgeons have to better understand brain processing and functional anatomy, which is normal to operate the brain, but radiotherapists can irradiate without any knowledge about the functional anatomy of the brain. And I say that I remember in Miami in front of 100 radiotherapists 2 years ago, you irradiate the brain as you irradiate the breast. And they told me, you're right, I'm still alive, but how we can accept that? I cannot.
Thank you, Professor Duffau. I really enjoyed your talk. Thank you.
Thank you.
Thank you, Dr. Nanda and Professor, for the answer. And I think we also have Dr. Julius Julai for question.
Mau tanya.
Thank you, Professor Duffau. Thank you, Dr. Selfie. Professor Duffau, your lecture is very inspiring, and I think it's opened our mind. I always enjoy your lecture. Regarding a patient's young age and come first time with seizure, with a very little change on FLAIR MRI, would you be confident to say that it's probably a low-grade glioma? And then how often actually you will redo the MRI and proceed with recommendation for surgery? Because sometimes it's just only the FLAIR changes, it could be something else, such as in Indonesia, it could be inflammation related with other things such as TB, infections. Thank you.
It's a very good question because we have submitted the paper about that recently in order to say we cannot operate an imaging. So we have to demonstrate the growth rate of the FLAIR. And this is the reason why I started my talk by that. And by telling we have to be objective to do the volumetric assessment and to benefit at least from 2 MRIs before to go to the OR, because there is no emergency. But you're right, if you have any doubt, you can do a 3rd MRI also, and then to increase the reliability, because we modeled about more than 1,000 low-grade glioma patients that the growth rate is between 3 to 4 millimeter of mean diameter a year. And because this is really sensitive and specific, that means that to answer clearly your question, how many patients are operated on for nothing, and the results of the lab was a posteriori, it's not a tumor, in my life is 0. And especially in incidental low-grade glioma, I will never, of course, remove an imaging typical for low-grade glioma in patients without any symptoms. I will first of all demonstrate a growth rate. And that means that sometimes I needed 2 years before to say to the patient, I'm sure that it's a low-grade glioma now because the growth rate was so slow initially that I did not see any significant difference within the first 6 to 12 months. And finally, it will be the message of the paper we recently submitted. 20 of my patients, so you see about approximately 1,000, are stable with a real stable imaging with more than 1 to 2 years of follow-up, and some of them more than 10 years. And they were referred to me in order to remove the tumor. And I said, no, because like in your example, I'm not sure that it's a tumor. So I will first of all demonstrate a regular constant growth between 3 to 4 millimeter of mean diameter a year. And if not so, I will not do surgery for nothing. So we have, first of all, to be connected to wisdom, if I can say, at least common sense, and not just to remove an imaging because we can't remove the imaging. Hippocrates never said primum non nocere, first of all, because he did not speak Greek, Latin, but Greek. He said, first of all, be useful. But if you cannot be useful, at least don't be harmful. It's totally different.
Okay. Thank you so much for the
Welcome.
answer. Thank you.
Thank you, Doctor. Okay. Thank you, Dr. Julius, for the question and the discussion. And we have another question from Dr. Rini. Dr. Rini, would you mind unmute?
Okay, thank you very much, Dr. Selfie, for this opportunity. Good evening, Professor Duffau. Since I'm a neuro-oncologist, I would like to ask you about the treatment. In high-risk patients with low-grade glioma after having a total radiation, should receive chemoradiation. But since it will increase the neurocognitive side effect, what would you recommend? Do we still have to do the radiotherapy or below the dose of the radiotherapy, or we just observe and do the lifelong radiographic surveillance, or what? Thank you.
Martin van den Ven demonstrated that early radiotherapy, as I said, did not change the median survival. This is a randomized trial. This is evidence-based medicine. So my question is why to irradiate earlier, since we demonstrated that we have not to irradiate earlier. Second, it has been demonstrated that if we radiate too early, we will induce a decline of cognitive function. So that means that we will not increase the median survival, but we will finally decrease the quality of life of the patient. I do not speak of course, just following radiotherapy, like following surgery. I speak 5 to 10 years later. We are not speaking about glioblastoma patients. Our patients are living more than 10 to 15 years. So we have to consider the long-term follow-up. And you know that in the New England Journal paper by Buckner et al., there was no cognitive assessment after 5 years. But the risk to see a decline of cognitive function is higher after 5 years. And they did only a mini-mental status, which is dedicated to patients with dementia, not patients enjoying normal life. Fourth, it's not possible to re-irradiate. In the vast majority of cases, more and more, I can do a second surgery or even a third surgery. In the vast majority of cases, you know that better than me, you are medical oncologist, you can give 1 year of temozolomide and to give again 1 year of temozolomide 3-4 years later, and then to control again the disease. It's not possible for radiotherapy. So if you put everything all together, if you want to preserve the quality of life of your patient, if you can reoperate, if you can sometimes reoperate thanks to chemotherapy inducing a shrinkage, neoadjuvant chemotherapy, why to irradiate too early? Not to increase the median survival, not to increase the quality of life, is the reverse, but also to decrease the neuroplastic potential not known by radiotherapists because they have first of all to be neuroscientists, as I said, to better understand the functional anatomy of this patient at that time, and of course to predict these modifications within the meta-network for the next 10 to 15 years. So I received in my department more than 600 people coming from more than 70 countries. Neurosurgeons, neuro-oncologists, neuropsychologists, neurologists, speech therapists, neuroradiologists, neurophysiologists, neuroanatomists, and so on and so on. You know the number of people involved in radiotherapy came 0. They don't want to know, to learn the functional anatomy. So we have a problem.
Okay, thank you. But you know why I raise this question, because in our country, the modality that covered by our insurance is only radiotherapy for this low-grade glioma. So they don't cover for the chemo. That's why I raised this question. So maybe we have to evaluate our, our treatment then. Then we should not do the radiotherapy for the low-grade glioma then. Thank you very much.
Welcome, but you can see once again, it's not just my view. You can use this paper by the ERNO, Monica Egi, once again, to defer radiotherapy preservation of cognitive function. And they propose to use temozolomide first. So it's not just Hugues Duffau in Montpellier, it's Europe, EORTC, telling 2 years ago in Acta Neuropathologica, be careful before to irradiate too early. Yeah. So you see that you have now a strong literature able to help you in order to say to, I understand, government for insurance, please give us a chance to give first a full temozolomide because it's better for the quality of life and the long-term follow-up. And then finally, of course, we will do radiotherapy in fine, so we can keep the ACE when it will not be possible to reoperate because the invasion of the connectivity and when temozolomide and or PCV are not helpful anymore. But once again, the vast majority of cases, including when we have foci of malignant transformation in the middle of the tumor, we have not to irradiate before in our institute 9 years. Okay. And our patients are living longer. So you have really the literature able to help you in order, to my opinion, at least to give you the opportunity to fight against insurance and to give the choice to the patient. Because I don't say to my patients, you have not to be irradiated. I give these parameters, but I said the tradition, the protocol today is to irradiate. What do you want? And some of them preferred to be irradiated. Okay.
Okay.
If they have the choice.
Mm-hmm.
Okay, thank you very much, Dr. Rini and Professor Duffau. Yes, this is amazing about the your protocol in radiotherapy, because I remember when I spent a couple of time in your clinic, I saw that you try to postpone the radiotherapy until you don't have any other choices. I think that's amazing because it's so different from what the protocol we are being taught for now. So I really hope that this can also open everyone's eyes that there are just one way right in doing it. I think the next question will be from Dr. Ahmad Farid. Can I mute yourself, please?
Thank you very much. Professor, I agree with you that we are neuroscientists with the same hobby. So my first question, that I believe you are not really trust the biological marker, right, Professor? So how you grading your patient? Basically, you mentioned about most of your cases is low-grade glioma. And my second question is your experience with all this resection also apply for high-grade glioma? Thank you very much, Professor.
Yes, and just to answer the first question, of course, I use molecular biology because you see on this slide, for instance, this paper has been published in Neurology just a few months ago. We used the WHO classification, otherwise no way to publish the paper. But we say just a part of the history. How to quantify? Once again, remember the preoperative volume related to the median survival. The growth rate, if the tumor is growing already 4 millimeters in 3 months before to go to the operating theater, I can tell you that it's a high-grade glioma, the behavior of high-grade glioma, whatever the results of the molecular biology. Third, of course, the residue. You see that here, the most important is to leave less than 1.5 cc of flare, objectively assessed, and not just the feeling of the neurosurgeon. Fourth, I have a very good neuropathologist who has the habit, of course, for more than 15 years to see many gliomas a week. And like I said, into the operating theater, it's better to have a good neuropsychologist rather than a good neuronavigator. It's better to have a good neuropathologist with a big experience rather than to have the good technology of molecular biology today, because it's not that I do not believe on molecular biology. I know that this is not the truth today, because based only on 1p19q, IDH1, and TERT if you want. So that means that you know, like me, that this is not the absolute truth of the full picture of the molecular pattern of the tumor. This is just a tip of the iceberg, like DTI for the white matter tracts, for instance. This is just a part of the truth. Now, speaking about high-grade glioma, it was not the talk today, and you can believe me or not, but in my experience of glioblastoma, I never published that. I will tell you why. The median survival is 3 years. Why? Because I will not remove the enhancement. I will remove more, and I will try to remove as much as I can of the flare according to functional boundaries and according to the same principle. But why I will never publish? Because when I started to say that non-officially to colleagues, they told me it's a bias of selection. You select people when you can do an aggressive resection. And I answered, but I thought that when I was a medical student, masters told me before to administrate a treatment, including surgery, you have to be helpful in order to select the good indications. So, of course, I will select the good candidate in order to be helpful, in order to do an extensive resection and to change radically the natural history of the disease, and not just to remove a small part of a butterfly glioblastoma in a patient with a 75-year-old, just to give him the opportunity to live 1 more month. Of course, we can discuss about that, but that means at least that in good indications, you can have 3 years of median survival without any severe permanent deficit except 0.5%. So the principle is exactly the same. My protocol is that I have no protocol.
Thank you very much, Professor.
Thank you, Dr. Ahmad Farid. And I think we still have another question from Dr. Suryani.
Thank you, Dr. Selvi.
Okay, thank
Very
you.
impressive lecture, Professor. I'll enjoy it so much. I'm a neurologist, so I think that the stimulation is look like we do the ECOG in epilepsy surgery. My question is, when will you do the stimulation of the patient brain? Is it during the day of the operation or days before? Thank you.
It's really online. The patient is awake. I'm doing the stimulation throughout the resection, from the beginning of the mapping into the operating theater, day D, until the end of the resection of the brain, according to the functional boundaries at the level of critical epicenters and the network. This is the reason why I'm sure about that, because I can see the modification of the brain online throughout the resection, thanks to the cognitive assessment, plus the stimulation mapping in real time in approximately 1 to 2 hours. This is the reason why this is not a long surgery, because you have to go fast. It's like a Formula 1 Grand Prix. You have 2 hours in front of you, otherwise the patient will be too tired. And this is the reason why it's totally compatible with a normal activity of a department of neurosurgery, because as I told you, at noon, maximum every day you have finished. So it's not like a complex implantation of grids or SEEG like in epilepsy surgery. It's really online decision-making based on the feedback provided by the patient and the stimulation at the level of the real modification of the connectome related to your resection.
So I mean the neuropsychologist also should be there during the operation.
Yes, I have neuropsychologists before to be objective, during to help me, of course, and to have this anatomofunctional correlation online the day following surgery in order to guide the post-operative rehabilitation. And 3 months later, when I will meet again the patient in order to check if he totally recovered before to return to a normal life, including working full time. So it's really online, if I can say, also a longitudinal serial cognitive assessment, and not just in this patient at that time and that's it. Everything should be a full picture with the fourth dimension. In other words, now we started to do neurocognitive assessment even 20 years after the first surgery.
Okay, I would like to have the protocol, if possible, to teach our neuropsychologists how to do the test so fast and in time. Thank you, Professor.
Oh, I can send you, but there is no protocol. In fact, it's related to these 16 functional domains we described cortically and subcortically. So that means that we have a panel of protocols, and we will select the good one according to the discussion we will have with the patient before surgery. As I said, for instance, to introduce calculation if the patient is a mathematician. While in the vast majority of the young population, they don't need to calculate anymore because they have the iPad. So that means that even 20 years later, the philosophy of the society changed, and as a consequence in my philosophy into the operating theater, the modulation of the task we can propose or not. For instance, in US, they will not do mentalizing because the most important is the externalization and the survival. So they don't want to be hemiplegic aphasic. Maybe they can discuss about cognition, but never about mentalizing. While in Japan, they introduce high-level mentalizing while we are mapping only low level of mentalizing into the operating theater. So it depends on the culture. So that means that, in fact, it's my question. What is your philosophy in Indonesia? But because I never came, as I said initially, I cannot infer your intention because I don't know you enough. But I hope we will meet in the next future in order to give me more data in order to know your philosophy, your concepts, your culture, and of course, according to that, you will adapt to each patient, but also in your environment. So it will be beautiful for me because I will have another point of view, another feedback.
Thank you very much, Professor, and thank you, Dr. Suryani. And Professor, we will arrange after this pandemic for you to come here as we promised before, and maybe we can arrange that you can perform a surgery and then everyone can be invited to learn together so that we can try to make everyone aware about this awake craniotomy. And I think I have one last question from the panelists. We have with us the guest panelist. I think she just joined us. Dr. Sylvia Shitsama is actually the first female neurosurgeon in Kenya, and she's just finishing her fellowship from Toronto. Please, Dr. Sylvia.
Thank you, Dr. Selfie. Thank you, Professor, for the excellent presentation. I'm very impressed. I'm well educated today. My question is regarding the cognitive assessment. I'm impressed at how much you're able to assess the patients, especially pre and post-op, and the deficits that you've been able to note based on the patients with low-grade gliomas. My question is, do you have a developed toolkit that is able to adequately assess, especially the emotions and secondary language?
Yes, because for emotion, more and more, we developed, I will show you again, at least into the operating theater, but of course, before and after surgery, we have more tasks in order to use read the mind in the higher task, which is very, very easy to administrate into the operating theater, but very complex for people to do. I mean, even outside the operating theater. You could be surprised, but when we started to ask what is the emotion expressed by this face, by looking at the eyes in front of you before to go to the OR to our patients, even in case of incidental discovery of low-grade glioma, we have 30% of errors. So that means that it's so complex to have normal social interaction regarding the high level, because we can decide just to map and monitor the low level of theory of mind, namely, so to perceive the emotion of others, but we can also increase the level by monitoring the high level of mentalizing, namely to infer the intentions of others. So you see that it's endless. And then we will not have exactly the same behavior regarding, for instance, psychiatrists. We would like to operate. It happened in my life. And of course, they told me I need absolutely to continue to have a perfect empathy. Otherwise, I will not be able to do my job with a high level of quality, despite the fact that I move, that I speak, that you presume my executive functions. While in some cases, more or less, they don't care because they have no empathy anymore before surgery. But we would like now to develop not most beautiful tasks, but program of rehabilitation based on a better understanding of the neural basis of empathy we started to describe, in order to improve the mentalistic state after surgery, as we can do for language, because for language, we model for a long time the dual stream with, as I said, the phonological pathways, of course, posteriorly, dorsally, the SLF3 with articulation, the syntax, but also the switch from one language to another one. Then you put the ventral semantic pathway with verbal and non-verbal, and the executive functions in order to maintain in your working memory the possibility to have so many informations, and finally to make a decision and to say something in front of me, for instance, in this office, when you are a patient after 2 hours of discussion, and by telling, okay, I understood, I would like to be operated on or not. And this is absolutely crucial because in fine, they made a decision by themselves. That means that they are motivated. And this is my secret explaining why they will help me for 1 to 2 hours into the operating theater, whatever the complexity of the tasks we decided all together before to go to the OR, because they want to do that and they will help you thanks to this motivation.
Thank you so much, Professor.
Okay.
Thank you very much, Professor and Sylvia. And I have one more question from the panelists from our neurobehavior team. So Dr. Asmelia, please unmute yourself.
Hello, Professor. Nice to talk of you. I'm neurologist from National Brain Center, Neurobehavior and Neurocognitive Division. I want to ask you about the mentalizing for the right side mapping. I'm a team of this Dr. Selfie in National Brain Center. We have 16, right? 16 operation with awake craniotomy in 2019. What about your experience about for right side mapping using mentalizing? It's usually using the eye, and we have a difficulties for the for the eyes. What about using the faces for the emotion? Can it be accurate with your experience in your operation? Maybe you can help us. Thank you, Professor.
So far, we prefer to use just IOS because it seems that it's a little bit more sensitive. And you know that into the operating theater, we have nonetheless to take into consideration the fact that, as I said, the time is limited, that the patient can be tired, and it's very difficult to use very specific tasks. Of course, we would like, as a neuroscientist, in order to better elaborate our new model of cognition. But we have, first of all, to be clinicians and to be really helpful for the patient. So as the neurosurgeon, I prefer to ask to my neuropsychologist to use more sensitive tasks, because when I will stimulate this network and meta network, if there is a disruption and if it's reliable, then that means reproducible. That means that I have to stop. And then it's really helpful for me because I am in agreement with the moral contract we had with the patient and the family before surgery. And then I know that I cannot push the resection anymore. Even if I am frustrated when we will publish this kind of paper by modeling the hemisphere, because we would like, of course, to have more information. And if we submit a paper to Journal Neurosurgery, they will say, beautiful, you introduce a new task, the patients are better. Are you sure that it will be not against the externalization and the median survival? So oncological issues, I answered this question just before. But if we submit in cortex or brain and cognition, they will say, oh, you have not completely understood the mechanisms because it would have been interesting to add another task, a high-level mentalizing task, as we said just before, or the face, as we said, and so on and so on. And of course, I will say, I cannot answer this question in theory, because I am first of all a surgeon, and what I want is to give the opportunity for patients to living longer and better. So this is the reason why it's very important to me also as a neuroscientist to have different countries, continents, cultures, as I said, because maybe you will not select exactly the same task as ours, like in Japan, high-level mentalizing, and then it will be infinitely possible to compare your experience, my experience with the same mind but different tasks, and then to better understand offline brain processing, and then to be able to help the young generation by publishing more accurate model regarding the neural foundations of theory of mind. So you see why to work all together and to build networks is absolutely critical, because I'm sure that your philosophy is not exactly the same than in Occident or Europe or like in US. So that's nice.
Okay, we should try Dr. Selfie. What is Indonesian like, right? Okay, thank you, Professor.
We will try. We will try, Professor, of course, with you being here. And
no, you will not try, you will succeed.
Thank you very much.
Sorry.
The motivation is keep inspiring me. It's always like that whenever I'm talking to you. Okay. And we also have the question from Surabaya, Dr. Neni. Please, Dr. Neni, unmute yourself.
Yeah. Thank you, Professor. I want to ask about usually in Surabaya we use language mapping with bipolar stimulation. I asked you about the motoric area, premotor epicenter. Do you use bipolar stimulation too? The first one. And the second, how the technique to uh, to evaluate the supplementary motor area, Professor? Because I have experience with SMA area. We have a technique with stimulation monopolar, and the patient after going to the subcortical, the patient going to the hemiplegia, and we stop the operation. What's the technique for the SMA area? Because many papers say that SMA area, if we get hemiplegic, it can come back for 3 months because the other side will be neuroplastic. Maybe I need your explanation. Thank you.
First of all, you have not to rely on fMRI, as I told you. And this is the reason why you were surprised maybe to see that the patient during surgery became hemiplegic. It was related to this fasciculus, namely the frontal striatal tract, which is just in front of the pyramidal pathways. So it's not just a problem of supplementary motor area, but a problem of networks. And in essence, fMRI is not reliable because it's not able to make the difference between the critical areas you cannot remove, otherwise the patient will have a permanent deficit versus a compensable activation. You can remove it, the patient will have a transitory deficit and finally will recover. But in addition to, as I said, it's impossible to see on preoperative fMRI the function of the white matter tracts, which are the limitations of neuroplasticity. The second point is that to remove the SMA, I will not stimulate the SMA itself if the patient accepted to have a transitory deficit. So it's a philosophical question we will have with the patient before surgery. Do you want to avoid any transitory deficit following surgery, but I will leave more tumor, especially in the SMA proper, and you decide? Or is it possible for me to push the resection? So if the patient is telling me I would like to have a perfect bimanual coordination, I will awake the patient. I will ask him to do a bimanual coordination during surgery. He will do also speech to answer your first question. So everything all together. And when I will stimulate a part of the SMA, but most of all, the junction between the frontostriatal tract and the frontal astron tract, then the patient doing that, yes, no, he will stop to move bilaterally and to articulate. And at that time, I will stop if he told me I don't want to have any severe transitory deficit. Otherwise, I will push until the pyramidal pathways, I will induce voluntarily the SMA syndrome, and the patient will recover, but not completely, especially speaking about bimanual coordination. And to do that, I will use in all cases a bipolar stimulator. I never used in 24 years any monopolar stimulation in my career. So it does not mean that you cannot use, but that means that it's not necessary. And I have no this kind of technical considerations, microscope, yes, no, navigation, yes, no, monopolar versus bipolar. You do not care if you know your functional anatomy and if you have the team doing the neurocognitive assessment online during surgery in a awake patient.
Thank you, Professor.
Thank you, Dr. Nimi, for the very important question, I think. Thank you, Professor. I think we still have so many questions. We have 22 in our question and answer box, but I don't think we can get through all of them. So I would like to invite the attendees that already raised hand from Dr. Silas Martins. Are you there, Dr. Silas Martins? Okay, maybe he's not listening. And maybe we also have this Dr. Ayman Mayas. Are you there, Dr. Ayman Mayas? I'm sorry if I pronunciate your name.
Yes, yes, correctly. Thank you very much.
You're welcome.
Hello. Thank you, Professor, for this wonderful presentation. I think you answer the most of my question during my listening to your lecture and answering of another participant in this lecture. But my quick question is, how is you dealing intraoperatively? I mean, that I understand you even maybe you will leave a remnant, no problem to leave a remnant. If you effect of the cognitive function or functional or connectivity of the patient. So that means maybe there is a remarkable residual sometimes with some patient. How you follow up the patient, I mean, every 6 months, every year. This is my question. I also write it in the question panels. And also question, do you serve doing frozen section during intraoperative frozen section? I mean, how, or only you rely on the cortical stimulation? I hope you understand my
cortical stimulation, on cortical and subcortical stimulation. Of course, I rely on the function. There is no interest, to my opinion, to use frozen samples examination during surgery, because in all cases, I will continue to push the resection until the connectivity will be encountered. So even if you tell me it's a high-grade glioma, it will change nothing for me, I will push. If you tell me you have left a small amount of residue in this location, I will answer, of course, I know that, but I will not cut the arcuate fascicle, because each time I stimulate, I induce a transitory a conduction aphasia. And what I want is, first of all, normal quality of life. So indeed, I left voluntarily for functional issues residue in many cases, as expected before surgery. So I continue to follow them. Indeed, with an MRI every 6 months, I follow by myself in addition to the team which referred the patient to me. And this is the reason why I have many patients with more than 15 to 20 years of follow-up. But in the meantime, second surgery, because the tumor regrew regularly, constantly, there is no stable tumor. And because we induced mechanisms of neuroplasticity, as I've shown on some slides, it has been possible for me to come back and to remove more during the second or even the third surgery, while in the meantime, the patient enjoyed the normal life. So that means that you optimize what I like to call the onco-functional balance, because the patient finally will live longer, because you will do a second surgery, a third surgery, but with a perfect quality of life in the meantime. And when the tumor is migrating to match in the connectivity, so I cannot reoperate because I cannot cut the arcuate or the IFOF, then I will push my neuro-oncologist to administrate a little bit earlier temozolomide or PCV if you prefer, but the quality of life is better with a temozolomide because better tolerance, in agreement with the discussion we had with the colleague neuro-oncologist, in order to induce a shrinkage at the level of the connectivity, and then to reopen the door to a second or third surgery without doing too early radiotherapy. So in other words, when I meet a patient for the first time in my office, we are trying to elaborate the individual strategy for at least the next 10 years since the beginning. After that, we adapt online, and after 20 years, to be honest, I don't know, because we have to invent new strategies, because remember, initially these patients were able to live only 5 to 6 years, so it was not expected.
Thank you, Professor.
very much, Professor. And maybe Dr. Silas Martin, I think you wrote already in the question and answer box, but if you want to talk directly to Professor Duffau, you just unmute yourself.
Okay, thank you. Could you hear me?
Yes.
Yes.
Okay, thank you, Professor Duffau. I was here on service last year. It's a pleasure to see you, to learn about you, and more to know about your service, more questions we have. So my question is, if you have a patient with some deficit in speech by the tumor or by some sequel by other surgery, do you indicate the awake surgery? And the other question is, when you decide to do an initial treatment with chemotherapy, how long do you wait to do the surgery?
First of all, if we give chemotherapy, when we will administrate will depend on many parameters. If we left more than 10 or 15 cc, if there is a migration, as I said, within the connectivity, so I know that I will not push plasticity too much at the level of the Y matter tract. If the growth rate is above 3 to 4 millimeters of mean diameter a year, eventually if nonetheless histomolecular pattern is not so good, if the patient continues to have some seizures, for instance, because I said that we were helpful in more than 80% of them, but not in 100%. So you see, in fact, we have so many parameters. That means that we will really adapt to each patient, but more or less, I will ask for chemotherapy, generally in my experience, within the 4 to 5 years following the first surgery, in case of incomplete surgery when I cannot reoperate because limitation of neuroplasticity. And of course, it's much more complex to answer your first question. If the patient already had any degrees of deficit before to go to the operating theater. So it will depend on the mechanisms. In other words, if it's a high-grade glioma, you can see without DTI, if it's really a mass effect at the level of the arcuate, for instance, speaking about language, so the patient has some difficulties to speak and to articulate because compression at the level of the SLF3 arcuate complex. Or if it's an invasion. If it's an invasion, you know that you have not to awake because in all cases, the patient will never recover because the glioblastoma already destroyed the SLF3 and or the arcuate. So it's a philosophical question because I will say very honestly to the patient and especially his family if he has some difficulties to communicate, your father will continue to have exactly the same deficit following surgery. He will not recover. So do you want to have any surgeries under general anesthesia in order to increase the median survival, but not without any improvement of the quality of life? Versus, you know that it's a mass effect. So you will go to the OR, and then finally, I will answer your question. I will do a debulking within the tumor and this glioblastoma under general anesthesia, because in all cases, I'm doing a sleep, awake, sleep protocol in order to open the skull while the patient is asleep, in order for him to be too tired when I will need his help. And after debulking, just in the middle, as classical neurosurgery, then you can ask to the anesthesiologist to stop the propofol, and you will be surprised, but in the vast majority of cases I did like this, the patient improved online throughout the resection. And then finally, it has been possible in the end of surgery to apply the concept of connectomal-based surgical approach I developed today, because the patient was more or less able to speak normally thanks to a mass effect decrease due to the first part of surgery. And then finally, to do a more extensive resection without any risk or even with an improvement of the quality of life. I like to do that, of course, because it's very impressive for you, for the patient, for the family, because the day after surgery, the patient improved while you removed the vast majority of the enhancement or even the flare. Once again, the most important is the selection of the patient, because you cannot do that if the fibers are already destroyed.
Okay, thank you.
Thank you, Dr. Silas Martins and Professor Duffau. I just want to mention one other question from Dr. Silas Martin that he wrote in the question and answer box, because I think this is interesting. He was asking whether you're using ultrasound. If yes, then how would you use it?
I use ultrasound just because, as I said, I have visitors, as you know, very regularly, or even for each surgery for more than 15 years, except in this period, of course. And I use it as a didactic tool just to tell you, you don't need intraoperative MRI, because even if, because you are younger, you would like to see the tumor, you can use ultrasound, you put the probe by yourself, and in 10 seconds, you can see the tumor. So that means that intraoperative MRI is never necessary. This is only the reason why I use it. When I am alone, I will just use my mental imagery and to do functional resection without any imaging validation, if I can say.
Thank you very much, Professor. I think this is also connecting to our next question is from Francisco Alberto Villegas. I'm sorry if I pronounce your name wrong. What are your recommendations for young neurosurgeons who want to develop, I think, knowledge, the brain mapping from scratch? I think this would be a very good learning for us.
This is the most important. You have to know the anatomy. And first of all, you have to do dissection of white matter tract in specimen, and to go to course or to develop, for instance, in your department, because it's not expensive and you need just a spatula. And when you did a surgery in the morning, it's absolutely beautiful to do dissection by yourself in the afternoon in order to understand better where you stop the resection and what happened when you stimulate it. Second, to use, of course, functional imaging, fMRI and DTI. Remember, I am PhD in this functional imaging, so I love it. But outside the operating theater, before and after, or to better understand maps, we have seen maps related to the control of movement, of mentalizing, and so on and so on. Third, to be connected to neuropsychologists, and at least when you are younger, to participate in the cognitive assessment, because suddenly you will say, oh, finally, this patient, I thought in my consultation that it was normal, and now I can see that he has so impressive executive function problems, mentalizing problems, and so on. And then it will be very helpful for you to select the good task into the operating theater, but also to know where to map, because you will start to build your own mental imagery based on the dissection you did, on the maps based on DTI fMRI, but also the cognitive assessment, and to make everything, to make the link between the anatomy, the radiology, the function. And of course, fifth, the most important, the follow-up, to do the follow-up by yourself. Not only by yourself, in order to be objective. I told you I cannot lie, because 90% of my patients are coming from abroad, but also by yourself. Because if your colleagues, your surgeon, whatever the country will refer to you, the patient and so on, the oncologist, the radiotherapist, the neurologist is telling you, don't worry, your patient is okay and is still alive, in a sense, if he's okay. So you're happy. No, you have to meet him, to save time in order to answer the good questions. What is your life? What is the difference between before and after surgery? And to make also the correlation with the objective cognitive assessment performed, as I said, 3 months following surgery, but also 10 years following surgery. And then you will build, you will make more reliable, more accurate, more subtle your own mental imagery. And if you want initially to use the neural navigator in order to know more or less where you were in the end of surgery, in addition to the functional mapping, please do that. But don't be addicted, because I know so many neurosurgeons not able to operate the brain if the neural navigator is broken. So that means that usually they are lost in the brain. And it's exactly what you should avoid as a neurosurgeon, because your plasticity is now beautiful, but you can believe me, the plasticity will decrease by becoming older.
Okay, thank you very much, Professor. I think we are already 30 minutes over time. So I think this would be our last question. This is from my neuroanesthesiologist team here. Dear Professor Duffau, my name is Dimas. During this pandemic situation, do you still perform awake craniotomy at your hospital? Can you share your experience how the anesthesiologists at your hospital do awake craniotomy using level 3 PPE, coverall suit, N95 mask, or face shield? Thank you in advance.
As I told you just before this webinar, it's a bias because we had very few cases, COVID cases in Montpellier. I don't know why, maybe the sun, the Mediterranean Sea, but that means that, of course, we were cautious at the level of the institute. But finally, into the operating theater, even if initially I did only big tumors or with mass effect, some glioblastoma and so on, I continued to do awake surgery, and of course without mask into the OR, because the speech therapist was approximately 1 meter to 1.5 meter away, which is good also because it increased the attentional processes regarding the work the patient had to do. So finally, it was not really an issue for us. And the most important was for the anesthesiologist, so to put the laryngeal mask initially and in the end, but they used at that time, of course, a mask with double security for them, and that's it. And we had absolutely no problems. But once again, because in fine, I don't think that I operated on any patients with COVID plus in my experience this past 3 months because of bias of selection.
Okay. Thank you very much, Professor. I would like to remind all the participants to please fill in the questionnaire, the polling, so that we can send you the certificate. The latest would be 1 week from now. And thank you very much, Professor. I think this is a very interesting topic. So that's why I have not told you before that we are actually have the maximum is 470 something participant. And currently, of course, a few have left. So we still have 458. And we actually have 931 registered from 45 countries. I think this is because of you giving the talk and everyone was very curious. And hopefully we can arrange another lecture from you, and maybe we can discuss about the specific topics. And we will email this to all the participants who would like to know more about this awake craniotomy. And thank you very much for everyone. And I hope that this eye-opening lecture can encourage everyone to learn more about awake craniotomy, how simple it is, how effective it is to gain maximal safe resection in low-grade glioma surgery. Thank you, Professor. Thank you all the participants, and thank you all the panelists.
Thank you for your invitation for this excellent webinar, for the discussion. And once again, we will have the opportunity to discuss again, to meet. And if you would like another lecture, I could suggest about insular surgery, because very frequently, of course, we discuss about the transopercular approach versus the transsylvian. And it's very difficult to understand the transopercular approach if we have not, first of all, understood this anatomy, especially at the level of the so-called Broca's area. I will be able to tell you more after tomorrow by email if you want, because definitely tomorrow morning I will remove a left insula with incidental discovery through the so-called Broca's area. So I will tell you what will happen. Thank you.
Okay, thank you very much, Professor. I already saw a couple of from the chat saying that they are want to have more a webinar on the this insular glioma. I think that is one of the most difficult gliomas that we are facing right now. Okay, thank you very much, Professor, and please stay safe, everyone.
Goodbye. Thanks.
Bye, Professor.
Bye, Professor.
Bye.
Goodbye. Thank you.
Thank you. Thank you, Selfie.
Thank you, Professor. I would like to remind all the participants who has not filled in the questionnaire, if you don't mind, just fill in. It will only take 5 minutes of your time, and we will send you the certificate. The latest would be 1 week from now. Thank you. And I would also like to remind everyone, because we are still in the commemorating of this World Brain Tumor Day. Tomorrow we will have Dr. Luis Borba from Federal University of Paraná, Curitiba, Brazil, who will give talk about transpetrisal approaches with the moderator of Dr. Ryan Rifaldi Keswani, same time. Thank you. Jadi stop ya? Are we still online? Dr. Rini, Dr. Nemi, Dr. Diorita, Dr. Sylvia, Dr. Viola, Dr. Asnel, Dr. Made, Dr. Sardiana, Dr. Adi, Dr. Boyke, Dr. Mustakim, Dr. Abrar, Dr. Ibi. Terima kasih banyak bertahan sampai
Terima kasih.
Oke, terima kasih, Selfie.
Jangan bosan-bosan diminta ininya, Dok, ya, bantuannya, Dok, untuk diskusi bersama.
Oke, sangat bermanfaat. Terima kasih, Selfie.
Terima kasih. Iya, mengingatkan lagi nih ASNO 2022 ya, Dok. Sebagai
Iya. Nah, nanti kita ini lagi, kita apa namanya? Kita undang lagi untuk kepanitiaan lagi ya.
Siap, Dok.
Dua-dua ya, itu udah dua-dua, Dok ya.
Dua-dua. Mereka kita waktu di BLO tuh udah setuju kok. Ya, walaupun dengan sedikit ini lagi tapi sudah setuju, alhamdulillah. Jadi kita 2022.
Oke. Siap, Dok. Hadir.
Oke, Mbak.
Terima kasih.
Live meeting ya.
Ya,
Bye.
siap. Terima kasih, Dok.
Assalamualaikum.
Waalaikumsalam, Dok. Mungkin bisa di stop webinarnya.